Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Okay, picture this. Someone suddenly collapses right in front of you. They're not breathing, and you can't find a pulse. Now, this isn't a heart attack. This is a full-blown cardiac arrest, and the clock is ticking loudly. What happens in these next few minutes is going to determine, well, everything. We're going to break down exactly what that means.
So before we can even get to the solution, we have to face the cold, hard reality of the situation. The numbers behind cardiac arrest are pretty sobering, and they really hammer home why every single second matters.
So what is a cardiac arrest, really? It's not a plumbing problem like a heart attack, a blocked pipe. It's an electrical problem. The heart's internal wiring just goes haywire and it stops pumping blood. Medically, we identify it with this critical trio of signs. The person is unconscious, they've stopped breathing or are just taking these weird gasps, and they have no pulse.
This number says it all. Across the globe, when someone has a cardiac arrest outside of a hospital, fewer than 1 in 10 will survive. That isn't just a statistic. It's a massive public health challenge. And despite all our medical progress, this number has barely moved for decades.
And if we look at recent data just from the US, the picture is just as stark. Only 9% of people who have a cardiac arrest outside a hospital actually make it home. Get this, even inside a hospital, the survival rate is only around 23%. This is the reality we're up against.
So how do we even begin to fight those odds? Well, the answer isn't some magic bullet. It's a clear, coordinated strategy. We're going to walk through what's called the chain of survival. It's the blueprint that takes us from those first critical moments through advanced medical care and all the way to recovery. All right, we've laid out the problem. Now let's talk about the solution. It's a really powerful and actually pretty elegant concept called the chain of survival. The most important thing to get here is that this isn't about one single heroic action. It's a sequence of steps. And just like a real chain, it is only as strong as its weakest link. You can see there are slightly different chains for arrests that happen in the hospital versus out in the world, but the core idea is exactly the same. A fast, coordinated response is everything. And this brings us to what is, arguably, the most crucial part of this entire system, because those first, most fragile links in the chain, they depend on one person. You, the bystander. This is where basic life support, or BLS, comes in. BLS is the absolute bedrock of survival. It all boils down to 4 immediate things you need to do. First, you have to recognize what's happening and call for help immediately. Then, you start high-quality chest compressions to manually keep blood flowing. And finally, you use an automated external defibrillator, an AED, as soon as one shows up. These steps alone don't restart the heart, but they buy precious time for the brain.
But it's not just about doing CPR, it's about doing high-quality CPR. That means you've got to push hard and fast, somewhere between 100 and 120 beats per minute. If you need a rhythm, just think of the song Staying Alive. You also have to push deep, about 2 inches. And this is key, let the chest fully spring back up. With every single push, you are literally being that person's heart, pumping life-saving blood to their brain.
So while CPR is keeping the blood moving, the AED is the tool that can actually reset the heart's chaotic electrical system. And these things are designed for anyone to use. Seriously, you just open the lid and it starts talking to you, giving you calm, clear instructions. For some of those chaotic heart rhythms, that electric shock is the only thing that works, and every single second you wait makes it less likely to be effective. Okay, so the bystander has forged those first critical links. They've held the line. Now the professionals arrive, and the chain gets handed off. This is where advanced life support, or ALS, takes over.
A huge part of advanced care is the drug epinephrine, adrenaline. And its role? Well, it's complicated. We know for sure that it's really good at helping get the heart to start beating again. We call that return of spontaneous circulation. But the big question, is what it does to the brain. While it can get the heart pumping, we're still not sure if it helps people survive with their brain function totally intact.
And this right here is a perfect example of how resuscitation science is always changing. For decades, drugs like calcium and sodium bicarbonate were just standard procedure, but now we have evidence that shows they just don't help and might even be harmful in most cardiac arrests. The guidelines are now crystal clear. Don't use them unless it's a very specific, very rare situation. At the exact same time all this is happening, the medical team is playing detective. They are running through this mental checklist of all the possible reversible reasons for the arrest. Could it be a massive blood clot, severe bleeding, maybe a drug overdose? Finding and fixing the underlying why is absolutely critical to a good outcome. Getting the heart restarted is a massive victory, no question. But the battle isn't over. In a lot of ways, it's just the beginning of the next critical phase, post-cardiac arrest care. This slide shows a really major, pretty recent shift in medical thinking. As soon as the heart is back, doctors get an ECG. If it shows a classic massive heart attack, that patient is rushed to the cath lab. But if it's not clear what caused it, the new priority is to get a whole-body CT scan. This lets doctors quickly hunt for other culprits, like a big blood clot in the lungs or a stroke, which need totally different treatments.
And this brings us to the newest and maybe the most human link in the chain of survival, recovery. We finally understand that just surviving isn't enough. These patients face a really long road of physical, cognitive, and emotional challenges. Supporting them through that journey is now seen as an essential part of a truly successful resuscitation.
And so it all comes back to this, doesn't it? We have the science. We have the blueprint with the chain of survival. We know for a fact that when a bystander acts, they can double or even triple the chance of survival. The entire chain, with all its amazing technology and medicine, depends on that very first link. So the question is, what's the biggest barrier stopping more of us from being ready and willing to be that link?
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.